by 65 First Friday webinars. We are collectively calling them Combating Pandemic Pounds and Corona Carbs. Today, we have the impact of obesity on hypertension. Dr. James Locke, he's an internal medicine specialist and hypertension specialist, and he serves as the medical director at East Central Mississippi Health Center. Dr. Locke, we want to thank you so much for consenting to do our presentation today. Thank you for being here. And I do have your slides. I'm going to call them up now, and then we will pass the mic to you.
Well, I just want to thank you for inviting me to do this. It's always a pleasure. And every time I prepare for these, I learn more. So that's a good thing. I need to keep learning as well as everybody else. Okay? It's a pleasure to do this because I'm passionate about hypertension. And today we'll certainly talk about obesity. How does that influence the development of hypertension? And hopefully just ask your questions at the end, and we hopefully can address some of your concerns and questions, okay? So with that being said, that's where we'll get started. What I'll do, most of these slides has what I call something to remind me what I need to talk about and keep me focused. I'll go through those and then I'll just summarize and put it in content so people understand it. So we'll get to the first slide here. The first slide is obviously the objective is to explain the effect obesity has on the development of hypertension. Because I call those two partners in crime because that's what it appeared to be like. Next slide. Okay, put us all on the same page. Actually, back in 2017, the American Heart Association, the American College of Cardiology came up with the new guidelines. And by now, I assume most people know that the changes they made in the guidelines for hypertension and the definition of hypertension has changed prior to 2007, since 2017. So to put us all on the same page, and we're talking the same language, you need to know what the new guidelines for us diagnosing what is hypertension. As you can see that, I put it down where we got systolic and diastolic, obviously. And you can look at that. I mean, the normal blood pressure, because patients often ask me, and I'm sure they ask everybody else, what is considered normal? Basically 120 over 80 or less is basically what we refer to as being normal. Prior to 2017, they had stage 1, 2, and 3, I believe. So now they got rid of this pre-hypertension and just call it either you elevated or you have hypertension. If you got elevated blood pressure, it's 120 to 129 over 80 or less. And stage 2 is, look like this, stage 1, I'm sorry. Stage 1 is 130 to 139 over 80 to 89, and stage 2 is greater than 140 and greater than 90. So that's kind of where we are. Now, Mississippi is a state that I live in, and I assume most of you guys are probably in Mississippi. Mississippi is the second highest prevalence rate of hypertension in the nation. Prior to 2019, I believe it was Mississippi #1, and West Virginia was number 2, but I think that has changed. As when I looked up data, the best I could find, Mississippi is slipped down to number 2, which is actually a good thing, but we're still too high. But we're number 2, and West Virginia is #1 when it comes to the prevalence of hypertension. As you can see, one of the major worldwide risks for developing cardiovascular disease is hypertension. Hypertension is the leading cause of death in the world, the most common cause of outpatient visit to a physician. Hypertension is also the most easily recognized treatable risk factor for strokes, myocardial infarction, heart failure, and chronic kidney disease. To put that together, basically, then we go back to the slide, then I'm going to go back and I just want to make sure we put that in content. And if you think about it, patients bring you information you need to know to deal with the thing that is the most common cause of death in the world. Now, I'm not sure where COVID-19 placed itself over the last year and a half. It may be the #1 cause of death in adults over the last year and a half. But if you take that out, hypertension obviously is going to probably be the leading cause of death in the world. And that numbers are growing because the prevalence of hypertension is increasing worldwide, particularly in developed countries. And something I just want to add to that is that if you want to prevent premature death, you've got to deal with hypertension in most cases, because hypertension touches, you see, heart attacks, heart failure, and chronic kidney disease. So what we noticed there, and this is something that people need to kind of keep in mind, because it kind of reminds people how serious it can be. If you go with untreated hypertension, you basically take about a half a day of life each month. Your blood pressure is not controlled. So you can add a half a day of your life each year by controlling your blood pressure. There's some data out there that tell us that someone that has a blood pressure 180 over 120, uncontrolled for 12 months, has a mortality rate of about 80%. That should be frightening. So for you healthcare providers, and certainly for a patient that goes to healthcare providers, if your provider is not addressing a blood pressure 180 over 120, or any blood pressure for that matter, then you might want to consider another provider. Okay, not that I'm telling you guys where to go, but that's how serious it is. Because I also work the emergency room, and I see these people come to the emergency room, and if their blood pressure is not controlled, sooner or later we end up diagnosing these people with strokes and heart attacks, and certainly chronic kidney disease. That is a very serious thing that if we recognize the hypertension and treat that, we can avoid a lot of the morbidity and death on these patients by just recognizing that. And that's the point I want to make sure I make, and that's why I put those bullet points in there to remind you of that. We'll go to the next slide. This is something I put in mainly because you notice obesity is in red, and that's what we're going to focus on today. But when a patient comes to the hypertension clinic, these are the things that we all need to be thinking about when we see someone come in with hypertension. Because before I became a hypertension specialist, I've always treated hypertension as an internist. But when I was studying for the exam, it reminded me that hypertension actually is a sign of a disease that's already in progress. And we need to think of it like that. So we see the numbers, we need to find out how did they get there? So if you don't treat the underlying cause, you just treat the numbers, some of the patient can already have something else going on that you also need to address. So when someone walks in your office, these things you have to think about. When I get referrals, when I do, I look at all those things and even more, but certainly look at those things. One is obviously excess sodium in our diet. And it's roughly, I got here 1.5 grams. I can't see because my pictures on that thing. I think it's 1.5 milligrams of salt per day, but that's roughly about 1 teaspoon of salt per day. And you can get that in probably a good McDonald's set of fries in one day, but it's not a lot of sodium you need. And age is basically, the older we get, the greater our chances of developing hypertension. Matter of fact, if you've got a normal blood pressure at age 55, and you live to be the typical life expectancy for most Americans, you got a 90% chance you're going to develop hypertension. That's how prevalent that rate can become. And it's because our blood vessels get much stiffer as we get older. So as we age, our blood pressure also increases. Of course, you need to be concerned about someone come in, ask about sleep apnea and all these kind of things. And I just skip over obesity right now. The sedentary lifestyle is important because we become couch potatoes, and the more we become couch potatoes, the more weight we gain, and most likely we will develop, hypertension. And drugs. This is something I want to stress, because when I said drugs, I get people come in, and sometimes I get referrals, and the providers often never ask these people about their drug use. When I said drug use, Smoking, which we'll get to in a minute as well, can increase blood pressure, certainly temporarily, okay? For a few hours, if you smoke and you come get your blood pressure checked. But also these illicit drugs like cocaine and crack and crystal meth, all those guys are stimulants and they increase blood pressure. You need to ask people about that. As you well know, if you any of you listeners out there, providers, you know that people often don't tell the truth about drugs. So oftentimes I will test the urine for drugs if I'm concerned about them being a drug user, and I find illicit drugs there oftentimes when the patient said they don't use drugs. But I need to know that, because if I can counsel them on that, then we can also get their blood pressure control. It's hard to get that control when they're taking substances that would increase blood pressure. And alcohol, as you guys can look up more of that in a minute, I'm sure. But the thing with alcohol is that, you know, moderation is just what it is, moderation. I mean, I think it's 8 ounce glass of wine a day and 2 beers a day kind of stuff. That's or either a shot of liquor a day. That usually don't affect blood pressure very much, but anything beyond that certainly can. And of course, here in Mississippi, I have poor diets. We eat too many supplements that is very high in calorie. Our caloric intake is probably the reason that we end up with this obesity more than anything else. Okay. And of course, smoking. Smoking used to be the most modifiable risk factor for us developing hypertension, but now, from my understanding, it seemed to be obesity because of the epidemic in obesity. Smoking is still there, but I think from my last reading, I believe the obesity have taken over smoking, modifiable. And hormones, you know, and we often see people on oral contraceptive, or whether it's the depots or anything like hormones can certainly increase blood pressure. So you need to ask those kind of questions. And of course, cushions, I mentioned that because that's a steroid producing tumor and people that can increase their blood pressure, and hyper and hypothyroid. And of course, there's other things too, but you have to think about those things as secondary causes that may cause hypertension. And of course, chronic kidney disease. So when you encourage people, always make sure you check people renal function if you deal with hypertension, because they require much more aggressive management of hypertension. Go to the next slide here. Okay, and this may be the last major slide, but the thing is that I want to make sure, like I said, we're all on the same page when we talk about classifications, because this is what the people at CDC and FDA and I, we all use the same information, so we're talking from the same information. So when you classify obesity, how do you classify obesity? And this is how we classify it. You can classify it more than just using BMI, but that's what we use in our office. And I suspect most people do, because it's easier to do it that way, because you're basically taking someone weight in kilogram divided by the square root of the height in meters, and that will give you the obesity. And I often tell patients this joke: if you can't remember that BMI, this is something that I may not need to say, but I'm gonna say it anyway. If your belly is fatter than your butt, you're probably obese. Okay, so that's just the way it works. Okay, but when we talk about obesity, when we use the BMI, normal is 18.5 to 24.9. That's what we say that a person is ideal body weight per se. And overweight now is classified between 25 and 29.9, and you're overweight. And when they say overweight, they include overweight, and oftentimes you put them together, weight and obesity. That's why you get this high number, sometimes up to 70%. But all that is not obese, but you include both overweight and obesity. They decided to put obesity in 3 categories, and the obesity, the class 1 would be 30 to 34.9. And obesity, class 2 would be 35 to 39.9. And extreme obesity would be greater than 40 BMIs. And that's important, because when you refer people for bariatric surgery, oftentimes some of the insurance companies will approve someone greater than 40 BMIs before they will think less than that, unless you can confirm they got a lot of comorbid conditions going on. So that extreme obesity is what they focus in on more than anything else when we make those referrals. Okay. And I guess that's well, actually, I do want to say this about obesity since I'm obesity. You know, when someone is hypertensive, 2/3 of people that's hypertensive is there because of the obesity. And that's why I'm glad that Dr. Sonja Fuqua, I believe that's right. Is that correct? Make sure I get your name right. I'm glad you got me involved to make sure we talk about this. And the last slide I'm going to go to is going to hopefully put that together, because that's what we're here for, to put that together. Why is that so important? Obesity and hypertension in the same court. Now, Mississippi does have the highest prevalence rate of obesity in the nation. West Virginia didn't get that from us this time. They're working on it, but they hadn't got there yet. Now, obesity makes the heart work harder by increasing blood flow. And blood pressure and increased resistance to blood flow, which puts a strain on the arteries. I'll come back and explain that to make sense in a minute. You know, if you think about it, the cells that we are concerned about in obesity is the hepatocyte, which is basically a fat cell. It stores fat cells and it secretes all these hormones that's got to do with blood pressures, and angiotensinogen is one of those hormones, and this leads to the retention of salt and water and this thing. And I know everybody has had patients that said, I retain all this fluid and stuff, and they're often obese, and it's because the adipose cell does secrete these hormones to make you retain more fluid. And I'll talk about that in a minute, like I said. And the activation of this RAS system that everybody probably familiar with or will become familiar with if you study hypertension very much. It's activation of the renin-angiotensin 2 to aldosterone and increased sympathetic nervous system that lead to vasoconstriction of the blood vessels. And I think I mentioned 2/3 of hypertensive people are obese, but to put that in content that makes sense to me and hopefully makes sense to some other people. If someone is obese, what you basically you got this visceral obesity we're talking about. You're supposed to have some fat cells, adipose cells in your body to cushion organs, and it's in the subcutaneous tissues to help cushion us when we get bumped and all these kind of things. But one of the main functions, obviously, is to store energy for us to use later when we're fasting. But if you have too much adipose cells or hepatocytes, they get larger as you store more fats. And what happens is it compresses the kidney. So when you compress the kidney, the blood flow to the kidney is impeded. So you don't get as good blood flow to the kidney. So the kidney will respond to that by increasing some of these hormones that we're talking about, like this aldosterone and angiotensin, and increase the sympathetic nervous system. So it causes the blood vessels to contract and get much smaller because as a response to not receiving very much blood, the kidney think that you get dehydrated. So what happens, it will make the blood vessels constrict to make the blood pressure go up, and it doesn't need to, but it will get higher. So that's why when we gain weight, all this happens. And we get all these things going on that the body just don't need. And you also make your heart work harder because as you gain weight, you get more volume of blood. When you get more volume of blood in the body, then the heart has got to pump the blood. So it's going to put a more strain on the heart. And as a result of that, the heart will eventually develop some heart failure. So all these things are tied to the increased weight. So obviously, the best way to reverse that is to lose weight. When you lose weight, you often don't lose hepatocytes, but you often shrink the size of your hepatocytes. Now, they can stretch too much like anything else, and you do get the fat cells dying. And because fat cells can get too much fat in it, and it can actually destroy the nucleus, and these cells can die. And that's where you get this inflammatory reaction that causes damage in the lining of blood vessels. And when you get that, you get this inflammatory, you heard this endothelial stuff they talk about, get damage in the walls of the blood vessels, and that causes blood vessels to get injured, so you get more plaque buildup. So all this is related to just being overweight sometimes. So it is very important that we keep that in mind, that we have to have weight loss as part of the process when someone is obese. Because and now what they're telling us that not only do you can use medications oftentimes, but it got to be part of exercise regimen. It's also got to be decreased caloric intake. So a lot of the people in behavior science that want to use behavior modification is getting more involved in the management of obesity. And we get to see how they're going to turn out. But I expect it'll be better what we've been doing, because we really is in a crisis for overweight and hypertension in this country at this point in time. So that's mostly what I've had to say. And if you guys got questions, please do ask. Okay, so we'll go to the next slide. And so that kind of tell you same thing you probably already know, my name and all these things, okay? And I'm at the Walnut Grove Hypertension Center today, and that's where I work. There are any questions though? I don't know what I did for time, because I hadn't seen my time so much, but we will open up for questions if people got questions.
Dr. Locke, you were perfect on your timing, and I do want to appreciate you for that. I will ask if anyone has a question they would like to ask. I do want to make a comment, but I'm going to give anyone else an opportunity to do so at this time. Okay, hearing none. I just want to say, and not that I want to submit that I have all the information as it relates to obesity, but I learned something new, particularly about fat cells dying. I didn't know that they could actually die, and as a result of that, cause an inflammatory situation within the system. That was new information to me. I knew that they could get larger, and I knew that they could shrink, but I didn't know that they would actually die. So they can get so large that they burst and die.
That's correct, yeah.
Well, thank you for sharing that. That's something that, like I said, new information is something that I will keep in mind. Well, we again, thank you so much, Dr. Locke, for taking time out of your busy Friday. I know you have to go and see patients. We appreciate the information. We appreciate you being timely, because we do want to make these just mental hygiene breaks, as I call them, little 30-minute webinars that we can share with our patients as an opportunity for counseling. I want to thank everyone that joined us to participate and to receive this information. And at this time, we bid you all a great Friday afternoon. Thank you so much.